Hello, everybody out there. You are tuned in to The Local Lens, the podcast from the Powell County Health Department and Kentucky Rio, where we go inside our community's experience with the drug epidemic. Our show is coming to you from Stanton, Kentucky, a small town nestled at the foothills of Appalachia. And on this episode, we are once again reaching down to Chattanooga, Tennessee to talk with Robert Childs. This is going to be part 2 of our 2-part series with Robert Childs. So if you haven't heard that first episode yet, then I definitely encourage you to go back and hear that. That's going to give you a lot of context for this one. But if you are here just on an interest of law, then we've got you covered here. Part 1 was called Taking Action. We were talking a lot about things that needed to be done and different types of programs that have been effective in the different places that Robert has worked. But this episode is going to be more about learning how to set up the rules of our society and the law to encourage people to live healthier lives. It can be well represented by this quote:
"Providing people legal backing to do the right thing is so important."
And there are certain things that pretty well need to happen for harm reduction to be effective. One of those things, for example, is the syringe exchange program, which, if you're unfamiliar with that is a program where people can bring in used syringes and exchange them for unused syringes. These help lower the spread of HIV and hepatitis C and other potentially deadly diseases, and they also put people in contact with healthcare providers, and both of those things are good things to be doing. So how do you make these kinds of programs legal? How do you get them written into the law and accepted as the normal thing, the normal way forward? Well, if that's the question that's been on your mind, then you're in luck, because it has also been on ours. You're listening to The Local Lens. I'm your host, Nate Brooks. These are our people using our voices, telling our stories, because no one sees it like we do. Now, just a couple notes I want to make before we actually get the interview going. We had to record this over a Zoom call, so if it sounds like we're just on a telephone call, that's because we pretty much were. So we apologize for the audio quality through this episode. And the other note is a bit more legally involved. We wanted it to be clear that Robert is not representing any organization or company in this interview. This is just us talking with Robert about his own personal life experiences. All right, well, I think our bases are covered now. Let's get this thing rolling.
Hi, everyone. My name's Robert Childs. I'm a technical expert lead with JBS International, and in my volunteer time, I run 2 small all-volunteer harm reduction projects, one in Southeast Tennessee and one in Northwest Georgia, that primarily serves people who use drugs and people who are recently enrolled in treatment programs that use evidence-based treatment, including methadone and buprenorphine.
There you go. So you're a busy guy then. Is that right?
Yeah, it's
Yeah. So was the doing that as volunteer work, did that just kind of happen once you got into the area and saw that it was needed, or how did that come about?
Yeah, when I moved here, it was shocking. I observed it was just shockingly and alarmingly difficult to gain access to harm reduction supplies. And so after seeing how bad it was and there being a lack of movement to serve people who are actively using and people enrolled in programs that provide medications for opioid use disorder, I was just so alarmed. I just decided to create a partial solution to the situation, because I can't stand it when people die from preventable deaths. So yeah, I partnered with Georgia Overdose Prevention in Georgia to gain access to supplies. I've been working with them since their inception, and found some great partners in Tennessee to work with.
So we did a Zoom call because Robert is currently in Chattanooga, but he's been all over the place.
No, I'm originally from Europe, and then I've lived in Oregon, New Hampshire, New York City, all over Carolina, and now live down here in Chattanooga.
Yeah. Okay. There's a lingering accent on some of your R's. So
Absolutely.
where in Europe are you from?
Wales, England, and Germany.
Okay, nice.
And then I have my parents from East and Southern Africa.
Okay.
It mixes up the accent a bit more.
So which of these places do you identify with the most? Because there's a list of about close to 5 for you personally, but
Yeah.
about 10 different influences going in there that you just rambled off. So
I'd say Germany, Oregon, and Southeast Tennessee are my 3 favorite.
So, in part 1 of our conversation with Robert, we talked a lot about the specific kind of work that Robert was pushing for, that he had seen to be effective, and what it was like to be doing this work on the ground. In this episode, though, we are focusing more on how the law is a very, very important part of the overall approach to making our communities healthier. And you just heard him give a long list of all the different places he has lived. And the first question I had out of the gate was, what is one of the biggest similarities between all of these places?
I think a lot of things is just really impacted by the law. And so in North Carolina, I was actually directly involved in creating legislation, organizing, implementing, evaluating, sustaining, and expanding harm reduction. And so I had the opportunity, like prior to living in North Carolina, to live in New York City, live in New Hampshire, live in Oregon, and see how harm reduction was implemented in all those states, which then impacted my thoughts on what do we want to try and get here. Talk to a lot of people who actively use, talk to people with treatment, talk to people in recovery, talk to professionals, talk to law enforcement, talk to other first responders, talk to legislators, talk to a lot of faith leaders, directly impacted parents, and formulating like what would be kind of like the best thing. And also having to take into mind, like, we're doing this in Carolina. Like, we can't necessarily pass some of the things that would have gotten passed in other states that may bleed blue. So, we had to think about like, what can we do? And at the time too, no state which had a Republican supermajority had passed comprehensive harm reduction law, right?
okay.
And so when we were looking at setting up programs and like trying to pass law, we had to think like, what can we try and get through? Are we going to have to do a piece by piece move here? Are we able to do like a full like reform and get some major legislation through? And also had to change the way we did organizing. So what I like learned in New York like didn't necessarily work in Carolina. And also just the style. Like in New York, I was just straight and to the point. And then in Carolina, I remember a legislator at the time who now is a congresswoman, Alma Adams. She sat me down. It's like, what are you doing? You can't do that here. She's like, I don't have much time. I'm going to spend some time with you and talk to you about how to do a bit more effective advocacy here. She spent 3 hours with me, just like randomly out of her day, and just being like, this is important. You need to do XYZ in order to do stuff. We need to, think about who's at the meeting, key stakeholders, messengers, etc. And really coached us up on effective advocacy.
All right, let's start getting into the weeds a little bit more. How do you change the law without using federal or state dollars? Just so you have the context, I will give you the exact scenario that I was thinking of when we started this conversation. Fentanyl test strips have been getting more and more popular over the past several months because of their use at helping people detect whether there is any fentanyl in their drug or not. If you are unfamiliar with fentanyl, it is responsible for pretty much all overdose deaths today. It is 50 to 100 times more potent than heroin, and it is also much cheaper to produce. A little tiny bit of this stuff goes a long way, and people oftentimes don't know whether it's in the drugs that they're buying or not. So it's a sneaky substance that makes the drug much more deadly if it's there, but it's almost impossible to know whether it's there or not. That's where a fentanyl test strip comes in. You can use this test strip to see if there is any amount of fentanyl there. Now, in Kentucky, since the 70s, fentanyl test strips have been considered drug paraphernalia, which that makes it illegal to possess a fentanyl test strip. Now, this test strip, once again, is something designed to help reduce the harm of doing an illicit drug. So now let's look at the big picture real quick. If fentanyl is currently killing as many people as it is, then why would it be illegal to use this tool that can help you find out if you have accidentally or unexpectedly gotten some fentanyl? Now, I know that that was a roundabout way to get at this one scenario, so let me see if I can put it a little bit cleaner. What do we do if the law is setting us up to be less safe and less healthy when we know that there is a safer and more productive alternative?
If the law is problematic, it should be amended. So, and if it's causing death, right? I would add, I'm not, talking about any specific legislation for your state, but in like what's happened in Georgia, they amended the law, right? What happened in North Carolina, they amended the law. What's happened in most states, like it's not of that much controversy anymore. Like it used to be. I remember when we started doing it in North Carolina, like it just oftentimes too, like we found a lot of law enforcement didn't really like, they're like, well, they already sell drug checking stuff in the pharmacy, so why are we going to get on you about strips? We passed a law anyway after I left Carolina, but I think like it's really important to allow people to use drugs and people in harm reduction and the health departments to do everything that they should be doing as a best practice legally. And so I'm somebody who's very pro, like, let's try and work on passing legislation to protect the people doing the work, because the work's hard enough. Like similar to like first responders, people doing harm reduction work are also, I would argue, like doing emergency work. And so they're seeing their friends dying, they're seeing their coworkers dying of drug overdose, viral hepatitis, HIV, endocrinitis, and other bloodborne infections, and also from trauma, right? And like it's like folks are seeing so much death. Like when I worked very actively in Carolina, we had a lot of people, like they didn't have access to preventative supplies. They didn't have access to another human being potentially when they were using who could look out for them. And people died. And it was really hard on our workforce seeing that much death. And also like people coming into the field have seen so much death. And it's really hard for a lot of folks to be like, people are dying and we're making like certain interventions illegal. Like this is ridiculous. And so, in a lot of states, we've seen some really great advocacy groups step up, step forward and often they're just like, they could be anyone. And they just are just like, I've had enough. I'm just going to start advocating at the General Assembly to push for positive change and good legislation. And now like we have really good resources with like model law. And so it's really good to see that there's been more of an embrace of putting model law out there. I recently worked on a model law for syringe service programs to really push needs-based distribution and following the evidence and following the input of people who've been directly impacted and making that into like model law legislation that any state can gain access to. And I think making it easier for folks to understand model law is also really important.
So on that note, let's try to understand a bit more about what model law is, because this was new to me as well. So it's kind of like a one-size-fits-all approach to changing laws all over the place. So, generally, how this might work in action is a team of experts on syringe exchange programs will spend a lot of time figuring out what is a good way that we can get syringe exchange programs started all over the country. What are the barriers we need to remove, the barriers in the law that we need to remove, and what do we need to allow and require these programs to do so that everybody can be on board with these programs operating. So that plan is what becomes the model law, and other places will use it as a model and try to replicate it. In other words, you could say that it is
being like a comprehensive law that basically states can copy, that's going to allow for maximum output, that follows peer-reviewed research, that also like does the most to hopefully destigmatize and enable programs to operate really easily. So say, for example, I would view a model law as one that also like promotes needs-based distribution, but also doesn't require 80 signatures on a local level in order for them to operate. So think about in a place that's really hard hit, local officials may say, for example, oh, I don't like that. That just promotes drug use, even when we know that's not true, right? But they may just be like, oh, I don't really like this. I don't want to hear. Can we put this somewhere else? Or I don't want it in my state at all. That's problematic when there's HIV or viral hepatitis or overdose, mass overdose events happening on a regular basis, because we know one of the top ways to decrease overdose is to increase the amount of SSPs.
And just to clarify, SSPs are syringe service programs.
Increase access to naloxone, increase access to drug checking, increase access to meaningful involvement of people who use drugs and those who've been impacted by drug overdose, HIV, and viral hepatitis. Like, we want to promote those things to decrease overdose. We want to promote those things to create positive change, to build connection and community, as well as folks often forget, like, SSPs also are shown to decrease community drug use, right? And so a lot of people don't think about that. And also, like, they also help first responders. So 1 out of 3 cops in their lifetime will get a needle stick. 28% of cops will get multiple needle sticks, right?
Wow.
And we know if there's a legal SSP, it will decrease needle sticks by up to 66% by first responders. So with first responders, like, oftentimes people think, like, what's the most common injury? Maybe being shot or stabbed or something like that. It's actually more like stuff like needle sticks. It's like getting blood exposures. It's like, these are the things that, you know, should be of large concern. And so in Carolina, we had a lot of embrace from the law enforcement community because they cared about not being stuck on the job, right? And the number one rule is to come home safe at the end of the day. And if there's a lot of people with used syringes and they can't gain access to new ones, I, as a law enforcement member, would be freaking out, because if I'm going to get stuck, there's a greater likelihood I have a viral hepatitis exposure, because people can't gain new syringes. And if they're reusing syringes, they're reusing equipment, it puts law enforcement, first responders, and healthcare workers at greater risk. And so for me, it's like, it's vitally important to have these programs to protect first responders, to protect people who use drugs, protect the community, decrease syringe waste, which is often like used as a way to kind of like get sour on SSPs. It's like, oh, suddenly there's syringes here. But oftentimes there were syringes there already, and like not having proper disposal is one of the things. Like, I'll pick on Georgia for a moment, because why not? So in Georgia, like, and in Tennessee, I'll pick on Tennessee at the same time. As soon as you step out of the, like, in Tennessee, it's not, but I'll just pick on Georgia for right now, because it's Tennessee. But in Georgia, like, when you step out of the SSP, like, you don't have legal protections. So like, can people bring like their biohazard back to the SSP? Yes, but I may be worried about it legally. If I bring it back, am I going to be arrested on the way?
Yeah.
Right. If I'm a known person who uses drugs, that's something I fear. If I'm somebody from the BIPOC population, that's something I fear. If I look different, that may be something I fear. Right. And so, like, that's a problem with the law, and that's why we need model law that will address that. So like in North Carolina, when we wrote the legislation, what we really wanted to push was protections for people who use drugs who are members of an SSP, so they can't get arrested, charged, and prosecuted for just going and having supplies, because we want them to stay safe. And so when we wrote the law, we knew that was really important. And also I knew from New York, we had to go to the community service board every year. And like, I was in a very progressive section of the city when I was working in New York City. And so like, I was never really worried about it, but I could totally see if I was in like potentially like Scott County, Indiana, I may be more worried about that. And so just like thinking through like, you know, how do we make sure these programs can operate, that they can operate in an evidence-based way, that they're not negatively impacted by law, so like they can just be shut down at any point because somebody doesn't like them that day, right? Because it's like, if you're not directly impacted, you may view this as like a nuisance in the community because you don't know about all the benefits that they have. And it also may be that local media doesn't have access to the knowledge base, the information around how these programs help people in the community who are directly impacted, and indirectly like the folks who aren't impacted. So say, for example, when I was living in Wilmington in my neighborhood, I couldn't go a day on my dog walk without running into the improperly discarded syringes. Couldn't go a day. And so I actually started carrying barbecue tongs and a biohazard container and picked them up every day on my dog walk. As soon as we legalized the SSP and we started it in Wilmington, publicly disposed syringes went way down. And like I knew some folks in local law enforcement that like, we stopped finding publicly discarded syringes because people suddenly had the legal right to dispose of them, right? And so like in our first couple of years of operation, we got way more syringes in than we passed out because nobody had ever had a place to dispose of them and didn't have to worry about being arrested for transporting them and dropping them off at the SSP. And so providing people legal backing to do the right thing is so important. Will there be some people who still do something because of fear of law enforcement, fear of stigma, fear of family finding out or friends finding out that they use? Oh, for sure. But can we get rid of the majority of them? Yes, we can.
Now, this kind of thinking is where something like the Good Samaritan law comes into play so well. The Good Samaritan law gives legal immunity to somebody that calls 911 to help with someone who is overdosed. A scenario for this might be that you and a friend are using and then they start to overdose. So then you can call 911, get them help, and not be worried that you'll be arrested for having a small amount of drugs on your body. What they say is an amount for personal use. You're not supposed to get in trouble for having that if you are calling to help somebody who is dying beside you. And those same protections also apply to the people around you, so nobody should have to flee the scene. The protection applies to the caller, the victim, and the people around as well. That's the kind of program that we're talking about here. So how do you get these things set up? Well, one thing you can do is you can find and amplify voices that people already trust.
That's why anti-stigma campaigns in multiple levels, using like especially key stakeholders from the community that people just naturally want to hear from. And I would make an argument in the South, especially like we're talking about faith leaders, we're talking about first responders, we're talking about executive leadership, and we're talking about parents, right? And so I would say like it's really important with messaging to have all those key stakeholders with directly impacted people who talk about the importance, an occasional public health nerd. But like but like Yeah, like it's just so vital in messaging, anti-stigma work, and like having good law that's going to back you up. So, and I can send you some links to put in the show notes, for example,
That'd be
that
great. Yeah.
talk about some of the model law.
Yeah.
But it's really important if we're wanting to reduce overdose to be able to do what we need to do legally.
And we do have those show notes included. We've got a link down in the bio that you should explore if you're interested in model law. Now, another big thing to consider for now is how do you get people to listen to you? How do you get people to trust you? Everybody on the planet likes to think that they have all of the answers. How do you get people to trust your answers?
I mean, and that's why it's really important to do work in a coalition, right?
Hmm.
So I'm somebody, I want people from all walks of life. I want folks who are unhoused. I want folks who use drugs. I want the faith community. I want I want law enforcement to be there who want to work on positive change in a community. And at this point, like a lot of our strongest allies and advocates are directly impacted law enforcement who've lost their kids, lost their siblings, lost their best friends, and want to see positive change. In some spaces, though, like people who use drugs, like may have difficulty being in the same room. So providing opportunities through multiple different ways, so folks feel comfortable all working together, and that may sometimes be some separate meetings, and that's okay. And finding some folks who are willing to sit in a room, that's okay. But providing multiple avenues for input and providing multiple messages, right? And so, yeah, they may not be able to hear it from me. Like, I'm not from this country. I'm not, I lived north of the sweet tea line, as we say. And so, I don't drink sweet tea, so I understand why they're like, I don't know about that guy. And so that's why coalition work is so important, to find the messengers who people can hear from, as well as bring in new messengers that they didn't know they could hear from. And like one of those like universal messengers we found is also parents, right? There's something, I'm a dad, and like I have one of my kids is definitely like a child who struggles with mental illness, and I see it when I talk to other parents who have kids who, have a kid who's struggling, how much it impacts everyone is kind of universal, right? And so finding some of those like universal messages, universal ways of talking to fellow humans and understanding each other, like that's really important with any public health messaging, any public safety messaging. Any of that is to figure out like what builds us in unity as humans, what builds community, what puts us in a space where we can understand each other and respect each other. And so one of the things we also did to fight stigma was, oddly enough, a media campaign with the folks who normally would criticize the work. We also did a lot of work in training law enforcement in understanding harm reduction. And we did that through crisis intervention team training throughout the state, based off like needle stick prevention, understanding drug use, overdose prevention and response curriculum being inserted into the work. We also did it from engaging high-level law enforcement from the Sheriff Association, Police Chief Associations, and also through holding statewide conferences where we do a lot of education. And we also built a quote sheet on support for harm reduction, which we circulated amongst law enforcement leaders, so they could be like, oh, my peers also are into this. I don't feel so isolated anymore, so I'm more likely to embrace it, where before I thought it was just me who was secretly into it.
And that is pretty much the guiding thought behind the local lens. Our tagline says, "These are our people, using our voices, telling our stories," because we know that people want to hear this from people that they might recognize.
Also, people want to sometimes hear the message from people who are just like them. So, I'm a public health guy. I love talking about the science and what the peer-reviewed literature. And I was like, here's what I'm hearing from people who use drugs in the field. That's a totally foreign language to some folks. And they want to hear it from other faith leaders. They want to hear it from other cops.
And that is what the local lens is about. It's about taking the time to listen to each other so we can learn how to do better.
how can we understand like your culture so we can better provide services and work with you? And like I'd say also like in innovations I want to see, and hopefully this isn't innovation, it's just be general practice, but involving directly impacted people in the work that we're doing. So oftentimes what we see in some of the projects is they don't involve people who use drugs. They don't involve directly impacted people. And then they're surprised that their interventions aren't working.
Yeah.
Right? Because they may not think, hey, my office is right next to the sheriff's department, and a lot of our folks don't want to see a member of law enforcement.
Yeah.
Right? Because they may be participating in the illicit drug trade and acquiring some drugs, and they're afraid of law enforcement.
Yeah.
Right? It could be that your outreach hours to reach people who use stimulants are during the workday, and people are working. Why aren't they coming in? They're working.
Yeah.
Is it because I have a really long training requirement and nobody has time with that? Is it because like there's no access to childcare and I can't get in, right? And so I know like one treatment center in Kentucky actually started a childcare, and I'm like, I love it. It's fantastic. I was like, what a great idea. What if like, and you know, just thinking about, and those are things, if you involve directly impact people, they'd be like, don't put your program there, or like, you've got to put it over here. You got to do it during these hours. You got to incorporate some people that people trust, because if I've been harmed by the health department, right? So I may have had something bad happen there. I don't want to go back. I may have been previously arrested and incarcerated, and I won't go anywhere near the sheriff's office. I may have had a negative interaction with EMS. I don't want to be anywhere near them. And so we need to like think and talk to people who use drugs to understand it, and also talk to them about evaluating the projects, right? And making sure that we're actually giving people what they need. So there could be situations where we're not giving them the supplies they want, and therefore they're not embracing it. So like maybe they want very specific tourniquets and cookers. Maybe they want something very specific and your program doesn't offer it, and so therefore they don't go there. And that's why they like spend the extra time to drive over to Western Carolina in order to get what they need, or they come down to Georgia, where I see a lot of people from Kentucky to get what they need, because they can't get it where they are, right? So when I am doing naloxone distribution at some of the MOUD programs that I serve, we see a lot of people from all over who are coming because they can't get anything where they live.
Now, if there is a through line between this conversation, I would say that it might be that if we want to do as good as we can for people, for the benefit of our people, then we need to listen to what is needed and let those needs shape our laws and services. Because after all, who are we trying to help?
Do you have any closing statements or anything? Closing thoughts?
Well, thank you for having me here today. It was great to spend time with both y'all. Yeah, so, you know, when I'm thinking about harm reduction, especially in the Southern United States, I think it's really important for folks to also think about sustainability and making sure you have the ability to pass out as much as possible to folks who are directly impacted, and make sure to link people to quality care. I think it's really important for folks to poll people who use drugs about what they need in services, what they need referrals to, what they need to feel comfortable in the venues that they're coming into. And so I think it's vitally important that we engage the population that we're planning on working with and making them as much of our teams as much as possible. And so that may look like we have to revise workplace policies so we can hire people who may have a criminal record. We may need to look at workplace policies that allow us to hire people who have used drugs in the past, right? And so we need to think about ways to compensate people. We need to think about ways to engage people and gain their input, and also become part of our workforce in order to meet the needs of what's going on in America. And what's going on in America is the worst situation around overdose ever. And with the rise of illicit fentanyl and its co-use with other substances, like we need to be stepping it up nationwide, because if we want to reduce overdose, we need to do active outreach to people who use drugs. And we need to fund access to treatment that's evidence-based, that meets people where they're at and works with them to make sure they can stay in quality care so we can see less overdose. And we need to create more wonderful recovery communities from a variety of different angles that meet the needs of the individual. For some people, that may be abstinence, and some people it may not be, and that's okay. Let's meet people where they're at and make sure they have recovery and support communities. The other thing that folks need, and I'd love to see more across the country, is legal supports. So we criminalize people more than any place on earth around drug use. And so it's really important that we provide people with quality legal supports so they can have really, they can make informed decisions about their future, right? So when I was in Carolina, I used to find folks into jail, and I was like, why are you into jail for, like they called 911, right, on a friend who overdosed.
Yeah.
And I'm like, what? And so we help them gain access to a lawyer and then help get them out of jail, right?
Yeah.
But folks need to know the laws. We need to educate people on laws. We need to help people clear up their legal situation when we have an opportunity to do so, because that may be the thing that's preventing them from getting work. That may be the thing that preventing them from getting housing. If I don't have work or housing, that's a problem, right? And so we need to support people being able to have more stability in their life, and therefore they need more legal supports as well as housing and employment supports.
Now, if you feel burdened by hearing this long list of what is needed and what should be happening so that we're taking care of people, you're not alone. It is exhausting to think about how messed up everything can be and how short we're falling. But we need to realize we are falling short, and it's up to us to turn this boat around. Now, we're about done with this episode, though. I think we've given you more than enough to think about for one half an hour. So now we're just going to leave you with a bit of a hint at what our next episode is going to be about.
The other thing, that's really important too, and it's often separated, but a lot of people who use drugs need quality mental health care. And the whole reason why somebody may be using is because they have untreated bipolar disorder. They have untreated something else. And so we need to make sure that we work with mental health providers that will see people while they're using, see them while they're in treatment, and see them while they're in recovery, in order to address the underlying reasons of potential trauma, as well as something revolving around their mental health, to make sure folks can work on positive change. One of the great things I've seen programs embracing is like low threshold access to buprenorphine. So in Beth Macy's new book, they talk about it a lot. But anything we can do, like I love partnerships between treatment programs that use methadone and buprenorphine and harm reduction, so there could be direct referrals. So like on the regular, when I was operating an SSP, people were coming in and asking like, hey, I'm ready for treatment. What can we do? And eventually what we did is we formed a partnership with the local treatment provider, and they actually started sending a peer over to our program, and they would just take people whenever they were ready. They're like, you ready? Great, let's go.
Be sure to come back next time for our interview with Raven Rock Health and Wellness, a new place in Stanton, Kentucky, offering mental and physical health services. And this does conclude our two-part series with Robert Childs. I would like to thank Robert once again for coming onto the show and sharing this very deep well of information with us. And we do have some information linked in the bio here, as well as a couple citations for some stats that he shared with us. And I would also like to thank you, all of our listeners. Please be sure that you're sharing this show with anybody who needs this information. This is The Local Lens. These are our people using our voices, telling our stories, because no one sees it like we do.